Welcome, everyone. Thrilling to have you all here. Thrilling to have Dr. McDonald and all the other speakers here with us. My name is Michael Fine. I'm a writer and community organizer, a family doctor and a public health guy, and president and board chair of Primary Care for All Americans. Thank you for joining us. People from 38 states and the District of Columbia and 322 different zip codes so far. With more to come, I'm sure, as time goes on. We are an organization that has tremendous opportunities, tremendous responsibility, and tremendous opportunities. We're beginning the training for our local and state work groups. We're doing some real serious thinking about workforce and the need to massively expand the primary care workforce in the United States. We're thinking about how to be working together to remove the roadblocks and the burdens so students from all our communities can become the health professionals of the future. And we're beginning to build a national coordinating council. This is a big, crazy idea that we can build a movement to provide primary care to everyone in every American neighborhood and community and build a healthcare system for the United States that is for people, not for profit. There are many different challenges and lots of different pathways we can take. We've got a zillion things we've got to do at once if we're going to get this done. But I ask everybody to think through what it costs us every single day because we haven't done it yet and what it will cost us if we don't do it soon. Now it's my great pleasure to introduce Dr. James McDonald, or I'm not really formally introducing him, just it's my pleasure to welcome Dr. McDonald. We spent 4 years working shoulder to shoulder, trying to prevent Ebola from getting into Rhode Island, working hard together on the opioid overdose epidemic. And we worked really hard to figure out how to bring primary care to all Rhode Islanders. Dr. McDonald is a wonderful, decent man, and he's a good guy, and we're exceptionally thrilled that he's both in the chair of the Commissioner of Health for the state of New York and that he's with us tonight. It's now my great pleasure to introduce our moderator for this evening, Dr. Elias Shafi, and to thank the Zoom Committee of Primary Care for All Americans, which organized the Zoom, to thank Dr. McDonald and all the presenters, and to thank John Wright, Brian Kaiser, and Patty Armstrong, our 8 Zoom producers. Take it away, Dr. Shafi.
Thank you, Dr. Fine. Hi, everyone. Good night. Thank you all for being a part of PC4AA, Primary Care for All Americans, where together we are building a movement to provide healthcare for all people, healthcare for people, not for profit, in every neighborhood and community. Tonight, we're here to both teach and learn from each other. We encourage you to ask questions, put them in the chat, and we'll answer them at the end after we hear from our keynote speaker of the night, Dr. James McDonald. But before that, we'll have Ms. Janie Pappas tell us about her experience with healthcare. Hi, Janie. Where are you joining us from tonight?
Well, my name is Janie Pappas. I'm coming to you from Naples, Florida. I live in Lexington, Kentucky also. I'm a mother and a grandmother selling real estate in Kentucky and Florida, and a historic preservationist. I'm honored to be able to be here tonight and speak to you. Primary care is as fundamental to the practice of medicine as kindergarten is to education. After being seen over 7 months by specialists at a comprehensive cancer center, well-renowned and specialist, I was sure that I did not have cancer. Finally, it was a primary care physician who said, you know, we're going to biopsy that. This is 7 months later. Squamous cell carcinoma metastasized to the lymphatic system. lingual nodes, pelvic nodes, para-aortic nodes. So it was a primary care physician who saved my life. If this had gone on any longer, I wouldn't be here today. So I can't emphasize enough the importance of you primary care physicians. It was also a primary care physician who introduced to the cancer specialists the use of Signatera, which can monitor my circulating tumor DNA on a molecular level, which assures me every 3 months that I remain cancer free. And so I have a huge debt of gratitude, and the oncologist due also to my primary care physician who introduced them to Signatera, which they are now using at the medical center. Also, I'll say one last thing, that often after having care, standard of care, and seeing your oncologist every day for months, you're just sort of left flapping out in the wind, knowing not what to do. It's then that your primary care physician steps forward and helps you get through this transition from seeing a physician every day and not knowing what to do to be proactive to continue your health. And I just am so indebted to you and can't thank you enough for all you're doing. It has to be available for everybody.
Definitely. Thank you so much, Janie, for that inspiring story.
Well,
Very inspiring.
Thank you. Very grateful.
Thank you so much for sharing with us. So now I'm so pleased to introduce our keynote speaker of the night, Dr. James McDonald, who's the New York State Commissioner of Health. Prior to joining the New York State Department of Health in July of 2022, Dr. McDonald served at Rhode Island Department of State of Health since 2012. He earned his medical degree from Loyola Stritch School of Medicine in Chicago, his pediatric residency in the U.S. Navy, and his preventative medicine residency from the State University of New York. His diverse career includes officership in the U.S. Navy, as well as private practice in rural areas where healthcare shortages exist. Dr. McDonald also served in the Indian Health Service in the Navajo Nation, serving as medical director of the outpatient medicine in Chinle, Arizona. Thank you so much for joining us, Dr. McDonald.
Well, thank you, Dr. Shafi. It's great to be with you tonight, and it's great to see some familiar faces and some old friends here too. So I'm going to share my screen in just a minute here because I wanted to run through just a few slides really quickly, just to sort of set the tone for our conversation tonight. And I think it's just important to have a common reference point when we're having a conversation. One of the things I want to do, though, is I want to give you a word, if I could. Sometimes I move my talks into just sort of one word a little bit. And part of that's because if you can just grab onto one word, I think sometimes it's a little easier to get the theme of what was the speaker talking about. So the word I'm going to give you tonight is the word trust. So I want you to hold the word trust in your mind, if you would, just as we go through our talk tonight here. I'm going to talk about something called an 1115 waiver, an investment in New York State. And quite frankly, most people don't know what the 1115 waiver is. And for the sake of our conversation tonight, it's a demonstration program that we got approved through the Center for Medicaid and Medicare Services for our Medicaid program in New York State. But I want to move to just a little bit about the New York State Department of Health to give you a little context of how I look at us, because the New York State Department of Health is a little different than other departments. One of the things about us is we're the largest payer in the state, which is only 7 states in the country that have Medicaid as part of their health department. We're also a very large health regulator. We regulate hospitals, nursing homes, adult care centers. We also have this huge public health mission. In other words, we do everything from WIC to Wadsworth. Wadsworth's our state health laboratory. By the way, I have 4 nursing homes and a hospital that we have as part of our Department of Health as well. And part of what I'm getting at is when you think about a state health department, they're not all the same. But how I think about my large health department is, what is my job here? Well, my job is to align all this so we eliminate health disparities. And I was careful not to say reduce health disparities on purpose, because we don't want to tolerate a little bit of disparity. We want to eliminate health disparities. And I often tell my team we're a health equity organization that happens to do public health. And when you think about primary care, I want you to hold the word trust in your mind, but now I want you to think about the term health equity, which is a word that people use a lot. Health equity isn't a New York concept. It's a national concept, right? But before we get to talk about that, I want to ask you a question a little bit rhetorically. Is, do we have a healthcare system in the United States or a healthcare marketplace? And one of the things I want to say is I think when it comes to a direct patient care experience, I think we all want the same things. And Janie gave a wonderful description, by the way, of what we all want. We want safe, affordable, high quality, accessible, enjoyable healthcare. I'd like it to be personal because that's me. I'd also like it to be one of those things where it makes sense to me. But one of the things I want to show you is, like, you might be wondering, why do I have a picture of the Humpty Dumpty nursery rhyme on the screen right now? And I would suggest to you that since you grew up in the United States, what you're used to is a healthcare marketplace that funds all the king horses and all the king's men. What you're not used to is the notion that it's actually far more wiser and affordable and just downright right to tell Humpty, my friend, you're an egg. You have no business sitting on a wall. If you must sit on a wall for whatever reason, let me build you a harness. Let me put padding around you. And a lot of times what the primary care physician is helping you do is solve your problem before it becomes a big problem. And if you look at how we look at media in the United States, when we look at medicine in particular, we tend to glamorize all the king's horses and all the king's men. We don't tend to glamorize, not saying we need to, by the way, the power of prevention. I would submit to you that when a child gets a vaccine to prevent polio, you never see a child with polio. It's a beautiful thing. But quite frankly, there's no story there because that's what we expect to happen. It's what should happen. Prevention, my friends, can sometimes be boring, but it's a beautiful, beautiful thing. But one of the concepts I want to bring into our conversation tonight is this notion about there's only so many dollars out there. And every dollar I put towards direct patient care isn't a dollar I put towards roads, bridges, schools, housing, safe streets, everything else I need to run a civilized culture. So part of why I give you that concept is we need to be careful how we spend our limited dollars. As a state in particular, we don't print money. Now, New York State actually defined and codified health equity in law. And I think this is important because when you think about primary care in particular, this matters, right? Because what we're trying to do is achieve the highest level of health for all people. It acknowledges focused efforts to address avoidable inequalities by equalizing those conditions for health for those that have experienced injustice, socioeconomic disadvantages, and systemic disadvantages. Health equity is intentional. You're trying to do something intentional by getting a primary care for all Americans system. So it's intentional. It only works if you try to do it on purpose. I want to talk a little bit about our 1115 waiver. We got it approved January 9th of this year. It's a lot of money. $7.5 billion, $6 billion is federal money. But the overarching concepts is, how do you blend population health, build social care networks, and strengthen the public health workforce? No, strengthening the healthcare workforce. And really that's what it's about, is strengthening the healthcare workforce. That's a lot of what we're trying to do with our 1115 waiver. Oh, and we do want to emphasize, it's not just care that occurs inside the exam room that matters. It's often care that occurs outside the exam room. The things that keep us healthy, like our social determinants of health, optimizing those, creating those same advantages for everybody. Because quite frankly, everyone should have the same advantages and should have to do that. So when I talk a little bit about population health and health equity improvement overall, if you look at the left, a lot of the money is going towards stabilizing safety net providers. In other words, stabilizing hospitals that work in communities with high Medicaid rates, and looking at a future with global budgeting and looking at value-based payments. But if you look at the right side of your screen, you really see we have a large investment in our primary care delivery system model, almost $500 million. And it's a statewide approach towards advancing primary care, but really looking at how we look at payment, more value-based, how we do things like incentivize patient-centered medical home. It aligns with something called making care primary. And the point is, there's a particular focus on children and moving towards value-based payment. And it's one of those things where what we're trying to do is make sure we have primary care that's really part of that patient-centered medical home, and really into a system that's more sustainable over time, less emphasizing fee-for-service, more emphasizing, value-based payments, but really healthy outcomes for people. Other couple of concepts I want to sort of bring into our conversation tonight is we have a pretty substantial investment in what are called social care networks. And really this concept is to have these designated Medicaid providers to do things like not just fiscal administration, contracting, data collection, referral management, community-based organization, capacity building, but really looking at high need populations that are eligible for this, helping us find out who are the high utilizers, how do we help people get the care they need, how do we help people who are experiencing unstable housing, because that's really important. How do we help people with 2 or more chronic conditions? How do we get them enrolled in a health home? Because that's something where if you give people that health home, it really helps them overall. Health homes are more team-based care, really more looking at medical and non-medical case management. How do we help people with other things that coexist, right? Substance use disorder, serious mental illness, intellectual and developmental disabilities. And it's really about addressing the needs for people across the age continuum. But it also recognizes sometimes you have to help people with their housing supports, nutrition, transportation, and other issues regarding case management. All right. I did talk about our commitment to the workforce. There's almost $700 million we achieved for this as well. Workforce initiatives, some of it's towards career pathways training, finding people to some degree in high school, but also in college, about making sure that they are, if they're interested in a healthcare workforce, they can find that. But really, we're trying to find people who are willing to work in communities where there's a high Medicaid population, 30% or more. Some of this funding is going towards workforce investment organizations. Really, it's going to focus on training programs for incumbent workers and workers newly entering the workforce, particularly the high demand direct care patient titles like behavioral health right now. And of course, we have some money for loan repayment, for people who work in high Medicaid areas. Dentistry in particular is an area where we have an awful hard time in New York getting people to take care of people on Medicaid. My last slide, talks a little bit about our commitment to health equity in New York, and having continuous insurance eligibility for kids, in particular under age 6 for Medicaid. The real concept here, though, is getting back to the word trust. Is when you think about, just going to your primary care provider. I've been one for almost 34 years here. It's really a continuous trust relationship that you have here. And the question gets to be, how do you provide it for everybody? What we're trying to do in New York is ensure as many people as possible, because right now that's the mechanism that works the best, is finding a model of payment that really helps people. So we did that through not just Medicaid, but through what we call our basic health plan, or in other words, the insurance plans born out of the Affordable Care Act. We just got approval Friday of last week to cover anyone up to 250% of the federal poverty line to basically get free commercial grade health insurance. And we'll be subsidizing people up to 350% of the federal poverty line to have decent commercial level health insurance. These concepts are important for us because really when you insure people, you give people the access they need. That's right now one of the best mechanisms to get people into primary care. I'm going to stop screen sharing in just a minute, but I do want to end on this note. We do have a podcast, and sometimes that's helpful. Let me stop now and answer some questions because I think the dialogue is more fun.
So we'll get to, thank you so much, Dr. McDonald. I believe the questions will come a little bit later. If you do have a question for Dr. McDonald, please post them in the chat below and we'll get to answer them, or later on our social media pages as well. While you guys submit your questions, let me introduce Dr. Donna Smales, my colleague at Jamaica Hospital, who will remind us why this work is so important to us.
Making sure everyone in all of our communities has the health insurance they need to pay for primary care is a critical challenge. Making sure that primary care practices are paid fairly for their work and not overwhelmed by bureaucratic requirements for billing and by the other demands of insurance companies and others, so that they can get their patients the care they need so desperately, is incredibly importantly as well. Making sure every neighborhood and every community has great primary care clinicians and practices, and that there are enough doctors and other clinicians to see everyone who is sick, especially the same day, is even more important yet. We have to nurture the young in our communities so that they become the nurses, the doctors, and the other healthcare professionals we so desperately need. This means we have to stand together, shoulder to shoulder, with our students and our residents and change things so that young people from our communities aren't pushed out of the healthcare system by huge student loans or by training system that asks for superhuman efforts but provides inadequate support.
Thank you, Dr. Smell. When we say primary care, we mean everyone. When everyone has primary care and when communities get primary care from the doctors and the nurses who are part of those communities they serve, the health of our nation improves as our communities grow stronger. So here's what Primary Care for All Americans is doing today, what we really need your help with. We're writing a resource guide and playbooks so communities, states, national level policy members have the information they need to provide primary care to everyone at their fingertips. We're building the training process so work groups in our first 3 or 4 communities will be able to help those communities join Little Scituate, Rhode Island, become the first places in the US where everyone has primary care. We are getting ready to assemble state work groups in a number of states to advocate for training more nurses and doctors from our communities who will return to their communities to essentially practice. Our movement really starts with you guys. By joining us tonight, by learning about how communities can provide primary care to everyone, and by bringing someone new back each week, we'll build this movement together. We need you to join a work group, hit volunteer on our website, tell us how you guys would like to help out, build this movement together. Together, we can make sure that everyone in the US receive equal health care and get equal health, regardless of where you live, how much you earn, what community you come from, or what you look like. Coming together tonight for this teach and learn in session, we're that much closer to bringing primary care to all. Together, we can build a healthcare system that is for people and not for profit. And yes, we can provide primary care to all Americans in every American neighborhood and community. So now let's get to the questions. Patty, can you share some of the questions from the audience?
Absolutely. Hi, everyone. I'm Patty. I am from Massachusetts. I'm a mom and a member of my local community. Thank you so much, Dr. McDonald, for sharing. Let's jump into a few questions. You ready?
Sure, go ahead.
All right. So what levers do states have besides Medicaid waivers to increase the number of people who have and use primary care?
Yeah, so I think main thing to do is build a workforce, right? Like we don't have the workforce we need. Quite frankly, we're used to not having the workforce, and it's something we need to change. So we do need to not just train more primary care providers, but also healthcare workers. And I don't mean just nurses, although that's popular, but like medical assistants. There's a place for anybody in healthcare. I think the other thing you look at is how we pay people. Quite frankly, the incentives right now are paying much like you'd pay a factory worker. Like you assemble this, I pay you for that. That's not how you should pay physicians, and not how you should pay physicians for the outcome of what they do. Third thing I look at is scope of practice. I think in particular, we need to look at like, when you have a licensed healthcare professional, what is their scope of practice? Because quite frankly, most people are working under their training and should be working at a level that makes the most sense for them. I think those are 3 different ideas that do make sense a little bit. I think part of what, I would say that what you think about is like, when you think about what's possible here is like, we've grown up in a certain system. And I think it's important to think like, well, just because we grew up in a system doesn't mean it's the right way to do it.
That's fair. So you've worked in New York, but also in Rhode Island. So looking at your work a little more broadly, does New York or any other state that you're aware of have a really good way to count the population that use or have advanced primary care available to them?
Yeah, and I think if you limit that conversation to just patient-centered medical home, any state can do that. But I think that's too narrow a definition in some ways. And one of the things I want to bring you to is like, I used to work in the Indian Health Service on the Navajo Nation. And, you know, one of the things to think about when you look at how the public health service built their hospitals, you know, when you look at, if you've seen one Indian Health Service clinic, you've seen them all. But there's something very beautiful about them, because when you look under every every Indian Health Service clinic, you'll see not just primary care, you'll see dental care, you'll see mental health, you'll see substance abuse care. If they're big enough, they'll have an inpatient hospital there as well. Oh, by the way, the largest part of every Indian Health Service clinic is their health department. So when I think back when I was on the reservation in Arizona, there were more public health nurses than there were other nurses. There were more Jeeps than there were other things, because that's what the need was. But it's interesting, when I went and visited one of our Indian Health Service clinics in upstate New York, the farthernmost part of New York in the Akwesasne region, there they were. Primary care, dental care, mental health care, all under one roof. Substance abuse as well. It's very normal. And I think you have to look to models that exist. Now, in some degrees, other places you see this are the Department of Defense has built clinics like this as well. Because when you have an incentive that's purely about delivering the best service and not about anything more than that, those incentives line up. So I think that's where I don't see states doing it as much as the Indian Health Service and to some degree the Department of Defense.
No, that's a great place to look. And part of what we're trying to accomplish here is, you know, where do we go? Where do we find answers that maybe people have already come to and really looking at? So one more question for you, and I'm going to turn to Margaret, who asked us, is the state doing anything to reduce the barriers to entry to health professionals? Reduced or no tuition for medical loans, loan repayment, any programming like that that you've seen implemented well or that would work well in your opinion?
So it's interesting. There's actually some medical schools in New York that are moving towards a tuition-free model, which I think is really interesting for primary care in particular. That isn't done by the state, though. That's actually done by, you know, foundations. There was actually just somebody who made the news in New York for $1 billion donation. But it really gets this issue of like, could you imagine if you didn't have to have all that medical school debt? I left medical school in 1990 owing $40,000, which at that time was not a lot of money. But when people are leaving medical school now owing $400,000 or $500,000, it's really hard to go into primary care. So I think one thing to do is, how do you make tuition really, really affordable? Now, to some degree in New York, we have state schools, so we help do that. But I think other things we have to look at is like, how can you entice people to get into school? One of the things we have in New York in particular is a diversity in medicine program. We fund that, where we actually fund some students of color who, for whatever reason, didn't make it into medical school, but we can put them in a post-baccalaureate program. They could be nominated for that by a medical school in New York. And that's a tuition-free program. And then they can, if they succeed in that post-baccalaureate program for 1 year, they then get into a medical school. So that diversity in medicine program, as far as I know, is unique to New York. We've increased our funding to that over the last couple of years. We actually just hosted a student on our podcast, New York Public Health Now, about that. It's coming out later this month. And she did a great job just talking about how wonderful the program was for her.
That's awesome. And, you know, hearing about that, it makes me at least have some hope for the future, right? That we are taking strides in some directions, and hopefully coming together, we can really start to move the needle more and more. So thank you for answering those questions. I appreciate the other questions in the chat. That's all we have time for right now. So thank you so much, Dr. McDonald, for your time and sharing your insights on primary care. I really encourage people to stay on. We have additional people from PC4AA that will talk through some of these other questions as we build this community. Dr. Fine?
Healthcare impacts everybody. The idea of building a movement is a huge, crazy, big undertaking. But the problem is that the folks who are profiting from this system, who are taking something like $2 trillion a year out of our communities, aren't going away because we just say, pretty please. They're not going to go away regardless, but we think we can change them when we all get together and build a movement and act together and work together from the ground up, community by community. When we work together, there's nothing we can't do. So please join us in reaching out to colleagues, families, and friends. Let's talk about this. Let's plant the idea that it's possible, that it's affordable, that it will save us a whole bunch of money and get us way better public health if everybody has primary care all across the United States in every neighborhood and community. This isn't a Republican thing. This isn't a Democratic thing. Again, this is an American thing. The cost of healthcare affects all of us, and we are the public in public health. We demand, we need, we deserve better than we've got. The time is now.
Thank you so much, Dr. Fine. Thank you, everyone else, as well. We encourage everyone to find someone new, get them involved in this very impactful movement, and bring them to our next Zoom meeting, which will be on March 19th. Our speaker will be Bryce Heinbog, who's the CEO of Concierge Nurse Navigator and the founder of Ashtabula, Ohio Community-Owned Health Plan. Register on our website, www.primarycareforallamericans.org. It'll also be in the chat below. While you're there, click volunteer. Let us know how you'd like to be an active part of our movement. And also click donate to support our work together with a contribution. Every little bit helps. Once again, we need and appreciate every single one of you for helping us spread our movement across the nation in order to get the change we need and you deserve. Join us again in 2 weeks. Bring one person each time. Better yet, bring 3, 4, 5. Healthcare for people, not for profit. Primary care for all Americans.
Please take a minute to complete our survey. We are always looking to get better and improve these Zoom meetings and grow as a community together. We want to hear from you. We also invite you to stay on and talk with board members of PC4AA. We want to hear your feedback, help us grow as a community.
Thank you once again, everyone. See you on March 19th.
Are there other questions?
Did our health commissioner sign off?
I think he may have. He had a child who needed his company for watching a video, and we told him that that comes first.
And I was one of those that agreed. And as one of the board members, I would have taken the executive privilege of asking the question of, as a chair of a department in New York, where he's the health commissioner, I spend about 25% of my time trying to recruit young doctors to want to stay in New York when the rest of the nation is offering them all kinds of incentives to stay on. And adding to that, I was not fortunate enough to graduate with 50,000 of medical debt. I graduated in 1986 with 250,000 in medical debt. And I now have a son that's a first-year medical student that told me, "Dad, you work too hard. I want to be a trauma surgeon." So we need to learn how to overcome those kind of things. And I can't blame him for doing that because he sees me work 7 days a week. So it's a problem. So I'd love to hear what the audience has to say.
Any ideas or thoughts?
I am a proponent of team care and population health management in the outpatient setting. One person cannot fix the world. Having a savvy team there and doing coordinated care around each patient-centered version does seem to reduce burnout. Can't publish the data, but clinics that go with a team care model tend to have lower turnover rates among the staff, higher satisfaction, and most importantly, higher patient satisfaction and higher quality outcomes.
Maybe
And I agree with you. The data clearly shows that. The data, people have a primary care physician, are more satisfied with their care, have lower healthcare costs, lower utilization, and are more satisfied with their care. So I think there is data to prove what you're saying, Dr. Sale.
Would one of the DPC docs like to talk about panel size a little bit in terms of burnout? Anybody? Julie? Maybe? I don't mean to put you on the spot.
Sure, I can I can speak to it a little bit. I work for, not in a traditional primary care setting, but I chose out of residency to work for a direct primary care practice that is all virtual. And that decision really did come from the fact that I wanted to be able to have more time with my patients. And I saw the other opportunities where, you know, people were working, like you said, Dr. Roth, 7 days a week. And, you know, just to keep up with your patients and all the work that's on your plate. And I could already feel myself feeling those signs of burnout just thinking about it. So I made the decision to and learned about the direct primary care movement while I was in residency. I found it to be a community of physicians who just had this deep passion for providing really good quality care with their patients. And it's sort of this, you know, small revolution in primary care. And so I decided to take that path, and it has been very meaningful for me being able to spend more time with my patients, feel like we can address their needs, and that I'm not constantly behind the 8 ball and feeling so rushed has been a gift for me. And I do believe that there's, you know, I think that there are so many amazing primary care doctors out there who've been doing this for years and are, I don't think I could do what they do, but I do think there's an aspect of this that we have to put our own oxygen mask on first, and we have to take care of ourselves so that we can take care of our patients. And the current system is very daunting, I think, for new graduates to think about taking that on and working for their entire careers in that system. So I think there is more, even by the time I graduated from residency, the incoming residents, there were already more and more of them that were aware of direct primary care and considering that option before they'd even completed their residency.
So I'd like to say, you know, Dr. Fauché, I know your work well. I've looked at it, and I think it's a great model. And there's not going to be one answer to this, which is why primary care for all Americans has not supported like one system of care, because it depends on the part of your country like that you're in and who you're practicing. In an urban inner city place like me, your method would be great, but you know, we rely on value-based purchasing to bring us in dollars that we could then spend on taking care of those patients. I have a question. I know there's a bunch of pediatricians on the audience. Do any of them have anything to comment about, you know, how we're looking at the healthcare system, about panel size, or how they're delivering care?
Yeah, I'm a pediatrician, and I have a lot of thoughts about how our current primary care system wasn't built to do what we are doing. You know, as someone who spends most of my time on prevention and on monitoring growth and development and supporting young families and families just starting out, the idea of coming to a doctor's office for a series of visits, mostly with a doctor or a nurse practitioner, doesn't really make sense. It's not what we would build if we were to build it. It is how we have sort of fit children into an already established medical system that was built for sick care. And I think I think it would be great to really, you know, do a human by design project around what would you build if your aim was to support healthy children and strong families, and certainly take care of sickness as it arises. But so much of what we do is you know, the former, and the way we do it sort of built into doctor's office visits is just silly. So
I agree with you. You know, I'm a very much a believer in integrative wellness and health, and if we don't get children from the start to improve their nutrition, their exercise, their educational parameters, like we are not going to make a difference in the healthcare system. Any other pediatric providers want to comment?
I'd like to comment, although I'm not a pediatric provider in the way that I think you are talking about this language. 40 years ago, my very first professional nursing position was doing exactly what Pat is saying, right? We nurses were the ones who were seeing those brand new newborns. We were doing the growth and development screening. We were administering, parental support. I just spent a couple of weeks on my nursing sabbatical, visiting with nurses in Ireland, public health nurses in Ireland, who are absolutely flabbergasted that we put newborn infants in car seats and drive them to physician offices for work that nurses should be doing in their homes, in their communities, right in a health center nearby. Those babies in Ireland don't see a provider unless they're ill, not meeting developmental milestones. The nurses do all of their vaccinations, all of their growth and development assessment. And I just will never understand that any system would support that those kids and families. In fact, a nurse said to me, "Are you trying to tell me that those doctors have blocks in their offices and they ask the kids to stack them? Where do they play with them so they can watch and monitor their development?" And I said, somebody took it away from us a long time ago, and it makes me crazy.
Yeah, I agree.
And so, Julie, if
But if you submit the right,
talk to me.
but if you submit the right code, you'll get 93 cents in a reimbursement for the block test.
That's true. Rakes raisin. That's one of
Get
my.
you very far. So we had a question from the audience about value-based purchasing. I guess we could get a lot of different ideas what that means, but to me, in an urban inner city environment, it's about us getting a chunk of money to take care of a population of patients, not to put them through the hamster wheel of the healthcare system and do lots of testing and treatment, but what can we do to take a population of patients and address their health-related social needs, address their nutritional needs, address their educational needs, and what can we do to make people healthy and allow the primary care providers to spend more time with their patients to address those needs rather than waiting for people to develop chronic complex illness and needs all kinds of fancy interventional things that we know are effective when we need them, but we know if we prevented them in 80% of the time, they would never be needed. So I'd love to hear comments on that. Any folks?
Why don't I
Larry,
jump? Why don't I?
Michael?
Yeah, I just want to jump in a little bit. Value-based purchasing is a nice idea to get more funds to flow to healthcare organizations and to begin to think about accountability for public health outcomes. But I would remind everybody that the history of health policy in the United States for the last 40 years has focused on how we're going to pay for care and not on creating a primary care delivery system that takes care of everyone. And that has left us with, 57% of adults who don't have primary care and a totally inadequate workforce. So I don't have any specific problem with value-based purchasing, except it's a bit of a distraction from the central job, which I think is providing primary care to everybody in every neighborhood and community. And really and making sure we have the workforce to do it and not quitting until we get that done and not getting distracted by all the various interesting CMS ideas about how to pay for care.
So Michael, I agree with you with that 100%, but it's a better distraction than the market-driven system that we have now that's based on big pharma and, insurance companies and big hospital systems that are not focusing on the care of the patients that we need to focus on. Other folks want to comment?
I find value-based care, I think it's sort of a double-edged sword. I think it focuses almost entirely on the individual. So I think actuaries at insurance firms are looking at individuals and sort of assessing, what's the upside of offering value-based care to an individual. But having been part of sort of like the rollout of these types of programs, it sort of neglects the community aspect of care and sort of affects beyond, an individual who is a row on a spreadsheet. So, I like it as a model, but I think in reality, I've sort of seen it struggle to make its way through, the insurance gates and, just even once it's approved financially, how is it actually executed?
Other comments?
Yeah, this is Pat again. I just think, value-based care, how the way it has been rolled out in that, you save money, you have shared savings, if you can do it for less, has never worked for kids. That kind of value-based payment will never work for pediatric care. And I think will only work temporarily for adult care, right? There's an end game there. I do think that value-based payments in our current system is really the only way to pay for team-based care. It's the only way to pay for your integrated behavioral health provider, for your care coordination, for your community health workers that are going to be part of your team. Fee-for-service doesn't work for that. So as a sort of an interim right now, I think, the devil's always in the detail, but value-based care potentially could pay for a team, which is a step in the right direction.
But one small observation is, as helpful as it is paying for team-based care, it pays for people who have sought care. It doesn't well pay for those people who haven't walked through our doors. It doesn't meet people in communities and identify the opportunities to work with people who felt or feel excluded or don't have an easy pathway. And that's why I think the sense of primary care for all Americans is that if we focus on making sure we actually provide services to all Americans, then we're going to be in a whole different place in terms of health equity, outcomes, and costs.
Michael, you stole my punchline from the lecture. Fee for service works for those who can show up, those who can show up. And you have to ask, why can't they show up? And it's usually involving social determinants of health, transportation, chaotic housing. The resources are in the wrong place and you can't get to them because you work 8 to 5 and the office is keeping banker's hours. When we have had success with value-based contracting, particularly with adult populations, and as Dr. Flanagan pointed out, it doesn't work great with kids. The greatest cost savings, the low-hanging fruit, where it really worked was preventing unnecessary ER use. That's where we made all the value. And how do we do that? By providing better primary care that's accessible in the evening hours and on Saturdays and weekends. And that's something that fee-for-service cannot and will not do because there's no money in operating a clinic at 7 p.m. at night. But for us, it was always provide people access, because whenever there's a resistance in the system, whenever there's a problem with the social determinants or a problem with access, the path of least resistance to get care is to go to the ER.
So Dr. Saul, I agree with you with that, but one of the benefits of value-based purchasing is that your focus is on doing what's right for the patient and not what's necessarily right on the bottom dollar. And you hit the nail on the head. Keeping millions of people out of our ERs is good for the patients. Might not be necessarily good for the bottom dollar, but it's good for the individual patients. Other commentary? Other questions, Dr. Fine, anyone else, or should we say goodnight?
I think it's time to say goodnight and thank you to everyone. And
Sounds good.
remind everybody how important you are in building this movement. I don't really think there's a way to go forward without a movement. And the only way we're going to build this movement is if you keep coming back and bring other people, talk about it, and talk to patients about it until we get to this being inevitable, because it's so blinking logical.
Thank you and good night, everyone.
Can I ask one quick question, Dr. Fine?
Sure.
And all? What are the statistics on the number of doctors, medical students graduating each year? Is it on the increase? It would seem like if more were turned out, there'd probably be more that went into primary care.
Well, I think that's, I mean, what we know is there are about 21,000 medical students a year, 35,000 nurse practitioners a year, I think. And I don't remember the number of PAs at this moment. The number of people who do and stay with primary care is shrinking down to about 20%. So, sorry for my cough. So some of us think the way to get at this is to quadruple the number of health professional students we're training and let them go for free and obligate, but accept an obligation to practice primary care in their own communities for 10 years. This is a fixable thing. It's like, it's a lot of money, but it's a tiny fraction of what we waste each year, which is $2 trillion. There's no reason we can't do this. The thing that's getting in our way is that we don't have the movement that makes it necessary and inevitable.
Yep. It sounds good.
Okay, good night, everyone. Have a good evening.
Thank you, everyone.
You all come back now.
Thank you.
Cheers.